Thank you so much. Good evening, and my apologies that my Spanish skills are not good enough to give my talk in Spanish. So I will do my best to transmit some information and share with you experience using vaginal laser therapy in female pelvic medicine practice. And as the introducer mentioned, I work at NYU in New York City. I've met many of you at the beautiful meeting that you hosted several years ago before COVID that I was invited to speak at. And it's a pleasure to have this relationship between our institution and urologists in Colombia. And I look forward to your feedback at the end of this talk, and I'm very curious to hear what the experience in Colombia is with the use of lasers for female pelvic medicine. So I have no disclosures that are relevant to this talk. The goal of my talk today is to discuss briefly some clinical definitions that we use when we talk about menopausal symptoms that affect the vaginal canal. I'll talk about the indications for use of vaginal laser, the types of thermal therapy and the types of lasers that are currently available. We'll discuss briefly the clinical applications for the laser therapy. I'll go over the current evidence that we have regarding laser therapy. And finally, we'll discuss how do we fit vaginal laser into our female pelvic medicine practice. And obviously, this crosses the line between urologists and gynecologists. In the United States, there are many non-urologists and non-gynecologists who offer these kind of treatments as cosmetic procedures for the vagina. So you can see this advertised by plastic surgeons, by dermatologists, all kinds of practitioners and medical spas. But I think it's important, and hopefully you'll learn from the talk today, that we need to be careful, who's getting their hands on these therapies and how they're being utilized and marketed. So just to review a few definitions to be able to really talk about the indications for the use of vaginal laser. We used to call menopausal symptoms in women that apply to the vagina vaginal atrophy, and that was retermed genitourinary syndrome of menopause. We know that this can be a very distressing condition that affects at least 50% of women in their menopause years, and this can happen right after menopause, but can also happen many years post-menopause. The majority of patients, over 70% of women who complain of genitourinary syndrome of menopause, complain primarily of vaginal dryness, but they can also complain of vaginal burning, feeling irritated vaginally, having discomfort and pain. And this, of course, can affect sexual function in a major way. We also know that these symptoms can cross over into the lower urinary tract and can lead to urinary symptoms, including stress incontinence, burning with urination, frequent urinary infections, overactive bladder, all the various conditions that many of us see day to day in our practice in both urology and gynecology. Another term to think about is something that is not so well defined or well understood, which is the term vaginal laxity. And this is really where many of the lasers on the market are being marketed as an opportunity to treat vaginal laxity. And I'll discuss later how we really don't have any significant evidence to show that laser therapy has a major impact on laxity. I think, first of all, we don't really know what vaginal laxity is. Are we talking about sort of a localized laxity of the vaginal wall as it becomes atrophic and less elastic and less lubricated from lack of estrogen in the postmenopausal years? Or are we also talking about laxity when it comes to pelvic floor muscles, whether it be direct damage to the muscles from previous childbirth or from pelvic surgery, or whether the muscles just become more lax as a woman ages, which would be somewhat expected. In many papers, they describe a complaint of excessive vaginal looseness, which can be an issue during sexual encounters. We really don't know the incidence of vaginal laxity because it's not well studied. And is it something that a patient is reporting, or is it really the provider, the healthcare provider, when they do an exam and assess the vaginal pelvic floor muscles? Are they reporting laxity based on a pelvic exam, which may not be the same as a patient reporting a functional laxity? We know that laxity can occur across all ages. It's not just in the postmenopausal years, can happen to young women. So we know it's not unique to menopause. So I think this is a term that is a little more difficult to understand. Finally, the term vaginal rejuvenation is also used a lot when we talk about vaginal lasers. These are various procedures, whether they be laser procedures or surgical procedures or topical procedures, that are intended to treat vaginal laxity, genitourinary syndrome of menopause symptoms, improve vaginal dryness and itching. Some vaginal rejuvenation procedures claim that they improve stress incontinence, pain with intercourse or dyspareunia, and even decreases in sexual sensation. These are often performed by all types of healthcare providers, not necessarily urologists or gynecologists, but many dermatologists and plastic surgeons, often performing these procedures without an intended medical purpose. So again, I think we have to be a little bit careful what we tell women about the goal of our procedures, and whether they truly achieve these goals, I think, is another story. So what are the indications when we talk about vaginal laser therapy? The primary indication is to treat the syndrome of menopause symptoms, such as vaginal dryness, pain with intercourse, itching, discomfort. These are really great applications in patients that are refractory to vaginal moisturizers and lubricants, or even in patients who have tried vaginal estrogen or DHEA suppositories in the vagina and have not had the improvement in the symptoms that they would like. I think laser therapy is also indicated in those women who have some relative contraindications to the use of topical or vaginal estrogen. And that's sort of a controversial topic, because we now have some studies showing that vaginal estrogen can be utilized safely even in women with estrogen receptor positive breast cancer or endometrial cancer. However, many oncologists are not comfortable allowing patients to use vaginal estrogen with those histories or with active disease. And I think this is really where the laser has a unique application in terms of safety and efficacy. We don't know whether the vaginal laser can help with recurring urinary tract infections in postmenopausal women. And I think that would be an interesting area to study that has not yet been well studied, as well as whether the lasers really have an impact on a woman's sensation of vaginal laxity. So I would put question marks for those last two categories. There are several types of vaginal lasers available. The primary lasers, at least utilized in North America, are the fractionated CO2 lasers. Mona Lisa is the most common in the United States, although there is another company, FemLift Alma, that also makes a fractionated CO2 laser. Erbium and YAG laser is less commonly used, but also marketed as a vaginal laser, and I listed the names of those products below. And then you have various companies that for many years have had radiofrequency lasers available, initially primarily intended for the treatment of stress incontinence, but as the fractionated CO2 lasers took hold in the market, many of the radiofrequency companies now are targeting the treatment of vaginal dryness, pain, and some of the menopausal symptoms. So these are the various lasers that are currently available. The fractionated CO2 laser works as an ablative laser. I'll get into a little bit more detail about how it works. It causes some denaturation of the vaginal tissue, particularly the subepithelial tissue, with remodeling of collagen and elastin. The erbium YAG laser is a non-ablative treatment, so it is meant to have a deeper effect in the subepithelial tissues rather than the vaginal mucosa. It has controlled heating of this subepithelial layer without burning or damaging the epithelial layer. that can be affected by the fractionated CO2 lasers. In both instances, you have remodeling of the connective tissue, particularly collagen and elastin, as I mentioned. And that's really how these lasers work, to sort of stimulate the vaginal tissues that have become somewhat dormant in the postmenopausal state. Fractionated CO2 lasers, the most common used in the United States for vaginal treatment, as I mentioned, are minimally ablative. They have been shown to be safe, precise, and efficient when used by dermatologists to resurface the skin. And that's one of the primary lasers used in dermatology. In the skin, it destroys both the epidermis and the dermis in a microscopic treatment zone, which leads to wound healing and the deposition of new collagen and elastin fibers. In the vagina, it restores collagen formation, as well as hydration in the subepithelial layer, and improves elasticity in that layer. It is indicated for the treatment of genitourinary syndrome of menopause, although, as I mentioned earlier, is marketed for many other indications such as laxity, stress incontinence, and sexual dysfunction. And this is the wavelength for the fractionated CO2 laser. On a histological evaluation, you can see in the images on the left here is the treatment pre-laser treatment, so atrophy with a thin epithelial layer and lack of these papillae that regenerate when you treat. So this is a histologic slide 1 month after a fractionated CO2 laser using the Mona Lisa. And you see thickening of the vaginal epithelium, the red layer at the top, lengthening of the subepithelial papilla, increased glycogen storage, and fibroblast activity. So it's almost like the laser is sort of reawakening these dormant tissues that have become atrophied. With the CO2 laser, the thermal effect measures up to 0.2 millimeters in depth, so it's a relatively minor area of effect, and that's why it's generally well tolerated and has been shown to be safe. The recommended treatments are 3 sessions of the laser treatment at intervals of anywhere from 4 to 6 weeks apart. And then patients may require booster treatments every 1 to 2 years, depending on efficacy and symptom improvement. The erbium YAG laser, which we use less of in the United States for the vaginal treatments, has a photothermal effect that's a little deeper compared to the fractionated CO2, up to 0.5 millimeters. It causes a mechanical pull in the deeper tissue layers with new formation of collagen, angiogenesis, and is used primarily, again, to treat vaginal atrophy symptoms, but is also marketed for the treatment of vaginal laxity. So this is something we utilize a little bit less in the United States. Finally, radiofrequency ablation, which has been around a little bit longer in our armamentarium and had been utilized historically to treat stress incontinence with very poor efficacy and results. But radiofrequency works in a different way with electromagnetic waves that generate heat upon meeting the tissue. This also leads to stimulation of collagen production and also leads to some inflammation in the tissue. It's marketed both for aesthetic reasons and for functional reasons like incontinence, but at least in the United States, we do not have FDA approval to use radiofrequency for some of the indications that it's marketed for, particularly for vaginal laxity. But many, many centers are doing this without the approval. So it's sort of off-label use. So in terms of the actual clinical application, this is a simple office-based treatment. It does not require anesthesia. We often apply a local ointment or cream to the vaginal introitus using what's called EMLA cream, which is really topical lidocaine or prilocaine cream. This can be left on for 10 to 15 minutes, and then we remove the cream. For any of you who use the laser, you know that you cannot put lubricant around the treating device because it interferes with the application of the laser, so it's important to wipe off any local anesthetic cream. It just sort of helps in women who are very dry and have significant pain to allow more comfortable insertion of the laser probe into the vaginal canal. Most women tolerate this well. There can be short-term burning and discomfort, generally treated with anti-inflammatories pretty easily. And there are two different settings for the fractionated CO2 laser, both using a separate setting for the internal vaginal canal, and then switching the settings to a different depth and energy for the treatment of the surface introitus and vulvar tissues surrounding the vaginal opening. And when we do the application internally in the vagina, you start at the deepest level of the vagina, so you insert the probe as far in as it will go, up to the cervix or the vaginal cuff, and then you sequentially treat at 1 centimeter increments the entire vaginal canal by rotating the probe in a clockwise or counterclockwise direction, so that you're applying the laser circumferentially and also longitudinally the entire length of the vaginal canal. So I'd like to just briefly go over some of the evidence for vaginal laser. I gave this talk about 1.5 years ago at a national meeting in the United States, and or maybe it was 2 years ago. And at that time, we had very little evidence to even talk about. Most of the studies were very small prospective studies or cohort studies with no control group, and really not well-designed studies. We have a little bit better evidence to go over today, particularly for the fractionated CO2 laser, but really very poor studies or any strong evidence to discuss regarding erbium or radiofrequency. So a couple of different randomized controlled trials have now been published. The first is what's called the VELVET trial. This was a multi-center trial done in the United States, randomized, comparing vaginal fractionated CO2 laser against the standard of care, which would be vaginal estrogen therapy. This was a very well-designed non-inferiority trial comparing the two treatments with an assessment of the safety of both treatments and the efficacy at 6 months. The only real problem with this trial is that initially, when the trial was designed, the recruitment was targeted at about 200 participants to meet enough power to call it a non-inferiority trial. Unfortunately, when the center started accruing patients, the FDA decided to halt the trial, not because of lack of safety or any problems or adverse events, but because they wanted additional regulations met from the laser therapy company, which is DECA from Italy, to have approval to use an investigational device in this trial. However, the authors from this different centers decided to go ahead and accrue data and publish for the first 62 participants that were randomized. So the trial is a little bit underpowered for what it was intended, but we can still review sort of the findings that they had because it is a well-designed study. So basically, they took 62 participants that were randomized either to get 3 laser treatments 6 weeks apart, as is intended by the manufacturer, or the use of vaginal estrogen therapy, initially daily for 2 weeks and then twice a week throughout the duration of the study. And all of these women had, if they had been on vaginal estrogen prior to the study, had to have stopped it and done a washout period. They were assessed at the 6-month time point. Sort of interesting how they assessed these women. Not only did they use various questionnaires, but they actually brought the women in and assessed them at the 6-month point by inserting various sizes of vaginal dilators to assess the caliber of the vaginal opening and see if there was a change in caliber. And they also asked these patients to rate pain with insertion of the dilator. In addition to that, the patients filled out various questionnaires, including a visual analog scale, rating their genitourinary syndrome and menopause symptoms such as dryness, burning, itching, and pain with intercourse. They filled out a sexual function inventory, another questionnaire looking at vaginal aging and how it impacts their day-to-day quality of life. They looked at urogenital distress inventory and urinary symptoms. And finally, the PGII, or the Patient Global Impression of Improvement score. And then finally, there were some more objective measures. They measured vaginal pH to see if the pH became more acidic again as the vagina became better lubricated, and the features histologically appeared more like a premenopausal woman. And they rated the vaginal maturation index based on biopsies. So the primary outcome, again, was a non-inferiority comparison of subjective improvement in vaginal dryness at 6 months between the laser group and those women receiving vaginal estrogen. Secondary outcomes looking at the vaginal health index and scores with vaginal maturation, quality of life effect, effects on sexual function and urinary symptoms, and then overall patient satisfaction. So a fairly well-designed study. What they found were there were no significant differences that were statistical between the laser group and the estrogen group in terms of vaginal dryness scores, overall atrophy scores, and multiple questionnaires regarding sexual function and urinary symptoms. The estrogen group did have a higher vaginal maturation index score when biopsies were done compared to the laser treatment. And the estrogen group was also more likely to have more improvement in their sexual function scores when looking specifically at the questions regarding arousal and desire. So these authors concluded from this multi-center randomized trial that vaginal laser is similar or non-inferior to vaginal estrogen when we are talking about improving symptoms related to atrophy, sexual function, urinary symptoms, and overall patient satisfaction. So in this study, looks to be equivalent to the standard of care, which is vaginal estrogen. And it's really the only study of its kind comparing the laser to vaginal estrogen, which I think most of us feel very comfortable is the standard of care for these symptoms. The next randomized study looks at the laser compared to a sham laser. So this is a double-blind randomized sham-controlled trial with 85 participants, so a little bit better in terms of recruitment and a little longer follow-up of 1 year. Again, all these women, all 85 participants, had 3 laser treatments performed 4 to 8 weeks apart. Half of the group received the actual laser, and the other half had a sham laser, meaning they did insert a probe, the machine was turned on, it was set at the lowest energy settings, so the patients were blinded, as was the provider performing the study, as to whether they were getting the actual fractionated CO2 laser versus minimal settings that really had no effect on the vaginal canal. The primary outcomes in this study were symptom severity, so changes in symptom severity assessed by visual analog scale. They completed a vulvovaginal symptom questionnaire, and they determined that the minimal clinically important difference should be at least a 50% decrease in symptom severity and in the scores on the symptom questionnaire. Secondary outcomes that were looked at in this trial, quality of life and sexual satisfaction. Again, the vaginal health index score, which was something that the provider rated based on elasticity measurements, fluid in the vagina, pH, epithelial integrity, and hydration. So some of these women also underwent biopsies, and then looking at vaginal histology. As I said earlier, the sham laser treatment was performed with the laser at minimal energy settings that has really no tissue effect, but the women didn't know whether they were getting the real treatment or the sham treatment. This study was all done at a tertiary teaching hospital in Sydney, Australia. So here you can see the visual analog score for overall vaginal symptoms, anywhere from 0 to 12 months. So these women were followed for 12 months. The yellow bar is the laser group, the treatment group, and the blue bar, the sham group. And you can see from a statistical standpoint, there's not a significant difference, interestingly, in the visual analog symptom improvement score between the laser and the sham group. So either there's a significant placebo effect from the sham group, or the laser just doesn't have the efficacy that was hoped for. The second score, which is one of the questionnaires looking at vaginal symptoms, had similar results, not a big statistical difference between the yellow bar, which is the laser treatment, and the blue bar, which is the sham treatment. So again, disappointing results here when looking at fractionated CO2 and sham control, as opposed to the first study, which compared it to vaginal estrogen. So no significant difference found in this study in about 85 women in terms of quality of life and quality of sexual function scores. No significant difference seen in the vaginal health index, which was a number of different things looked at, including lubrication, elasticity, pH, and histology. Overall, when you looked at the laser versus the sham treatment groups, anywhere from 44 to 68% of women did experience pain after the procedure, which was self-limited. And this study concluded that fractional CO2 laser versus sham did not significantly improve vaginal symptoms at the 12-month mark. So a little different outcome than what we would necessarily expect. And this is the final randomized controlled trial, again, a multi-center study. This was double-blinded and placebo-controlled, so the same idea of giving a fractionated CO2 laser versus a sham laser treatment. They recruited 60 participants, and this was done in 2 centers in Greece and in Italy. The outcomes were, again, visual analog scores for dryness and pain with intercourse, as well as female sexual function index and urinary questionnaires to look at those symptoms after treatment. Again, similar to the prior study, if you look at, this is the active group, so this is the group of women that received the laser treatment with fractionated CO2. The symptom scores at baseline in the dark gray bar, and then the improvements or the change in symptoms seen in the light gray bar at the 4-month time interval after receiving the 3 treatments. So this is a little bit shorter follow-up of 4 months, but no really statistically significant improvement overall when it comes to urinary symptoms, although more marked improvement in vaginal dryness and pain with intercourse, which is what we would have expected. In the sham treatment group, really no change across the board in vaginal symptoms, sexual function, and urinary symptoms. So it seems that in this particular study, perhaps less of a placebo effect from the sham group. So they concluded that active fractionated CO2 laser treatment is superior to the sham treatment in improving dryness, dyspareunia, and some sexual function questions. The limitations, of course, it's a small sample size, and we know that with new technology, there can be a significant placebo effect. This study had shorter term follow-up of 4 months. And I think one thing that we've learned from many of these studies is, although the regimen of treatments is meant to be 3 treatments initially spaced 4 to 8 weeks apart, perhaps we need to think about whether the frequency and the number of treatments needs to change, and perhaps we're not treating effectively enough with those 3 treatments in the time intervals that were initially determined. When it comes to erbium YAG laser, as I mentioned earlier, really not great quality studies. Most of them are prospective, small case series with short-term follow-up. There was one prospective study, which was called the Vaginal Erbium Laser Academy study. This was a multi-center study, longitudinal in nature, but no control group. It did have a larger number of women, 205 women with a 2-year follow-up. And in this study, they did show decreases in vaginal dryness and pain with intercourse up to 12 months with a decline as expected afterwards. But I think the real problem with that study, although the results look good, is we don't have a control group or any comparison to standard of care. And finally, looking at radiofrequency, there was one multi-center prospective randomized sham-controlled study looking at a monopolar radiofrequency device with a primary endpoint at improving vaginal laxity, or that patients reported no vaginal laxity on a questionnaire at 6 months. This was one single radiofrequency treatment that was applied just to the vaginal introitus versus a sham treatment. So here, again, the target being a little bit different in terms of improving laxity. And they found that 43% of patients in the treatment group compared to 19% in the sham group reported no laxity at 6 months. They did find significant improvements in the female sexual function index scores in the treatment group. They did not mention in this study any safety or adverse event issues, which I think is a little problematic. And we know from this study, again, that there can be a significant placebo effect in the sham group just from using the technology. So sometimes it makes it a little harder to interpret, although theoretically this was a randomized controlled study. The laser has also been marketed or discussed as possibly improving recurring urinary tract infections in women. I think if I knew that this worked, probably 50% of my practice would be signing up for vaginal laser at a substantial cost, because we know the public health burden from infections is significant in women. This is one small study from 2016 and really nothing since, looking at the vaginal microbiome and the effects of laser. It's a group of 53 women that were followed prospectively, looking at fractionated CO2 laser and how it affected the vaginal microbiome. They did show a reduction in pH back to an acidic range, an increased predominance of lactobacillus, which is what we want in the vaginal canal. However, they really didn't study whether this changed a woman's risk of urinary tract infections. So I think this is yet to be determined, and probably a really great area for further study if somebody can do a better study that's controlled and perhaps look more carefully at the frequency of the laser treatments and whether that, as I said, needs to be changed. So I would say overall, in terms of evidence, we have 3 randomized controlled trials, primarily looking at fractionated CO2 laser, which demonstrated mixed efficacy in the treatment of genitourinary syndrome of menopause, meaning some studies showing some improvement, benefiting or weighing towards vaginal laser, whereas others really were more equivocal. We do not have any long-term studies. So, really what most of us feel is that we need well-designed sham-controlled trials, as well as more comparative trials with standard of care, such as vaginal estrogen, and longer follow-up. What I can say is there really is no significant evidence for the use of the vaginal laser to treat stress incontinence or overactive bladder symptoms, although it is marketed by many, many practitioners for those purposes. And in terms of gynecological cancer patients, particularly breast cancer and endometrial cancer, we know that the laser is safe, but again, the efficacy is equivocal in these patients, but a reasonable thing to try, especially if their oncologist is not allowing them to use vaginal estrogen. So just to sort of, discuss how we use it, how I use vaginal laser in our practice at NYU. It is something we've had for a number of years at NYU. I think in the United States, the biggest barrier to the use of lasers, probably similar in your country, is that it is a substantial out-of-pocket cost for the patient. It is not covered by insurance, very similar to dermatologic lasers that are not covered. So it is a minimum expense for 3 treatments of anywhere from $2,000 to $5,000, depending on how much the practice charges for the treatment. So I really like to offer the laser to women at the very beginning when we have a discussion about how to treat their genitourinary syndrome of menopause. I'd like to give them an overview, just like I do for overactive bladder, of all the various options in treatment. But I think the ideal patient is a woman who has tried vaginal estrogen, has not had the improvement in her symptoms that she's wanted. I do think it's can be a primary modality in the treatment of gynecologic cancer survivors with endometrial or breast cancer that's estrogen receptor positive, and their doctors don't want them using vaginal estrogen. But I think what would be more interesting is a study to look at whether vaginal laser therapy can be an adjunctive therapy to vaginal estrogen, because we've all seen women who use vaginal estrogen religiously, but just don't get the benefit that they would like So perhaps a combination of interval laser with vaginal estrogen or other forms of hormonal therapy given locally could further benefit symptoms. I think we don't have an answer about whether this is an application for women who are postmenopausal with recurrent UTIs. And there's also discussion amongst dermatologists whether this can be offered to patients with vulvar dermatoses, such as lichen planus or lichen sclerosis, that is not responsive to standard topical steroids. And I've actually been referred some patients from dermatology for the use of the laser in those cases. I can't really give you a good answer as to whether they're effective or not. I haven't done enough to really be able to make that conclusion. So I think it's important, like anything we do in pelvic medicine, you need to have an informed consent with the patient. They have to understand what we know and what we don't know about vaginal laser. And if they're willing to pay for it and try it, particularly if the goal is to treat atrophy symptoms, I think it's very reasonable. I think to tell a woman that it's going to cure her of stress incontinence or improve her libido or sexual function is a little more questionable. I don't think we have that evidence. As I said, it can be applicable to the gynecologic cancer patients, to vulvar disorders, but we really need better long-term trials with better follow-up. So I think out of all the healthcare practitioners out there, we are the best equipped as urologists, gynecologists, urogynecologists, pelvic medicine specialists. We really should be the ones leading the charge with vaginal laser. I don't really think it's appropriate for a plastic surgeon to be offering this in their practice if they really don't understand what symptoms they're treating and what the standard of care in treating those symptoms is. So I think we need to set realistic goals with patients, just like we do with any of the quality of life conditions we treat in female pelvic medicine. We would expect short-term improvements in dryness, pain, itching, burning, discomfort in the vagina, but it will require repeat treatment, and we probably don't have the best idea about the interval the treatment should be offered, but they will need maintenance treatments periodically if their symptoms decline. And as I said, I would find it interesting to use it as an adjunct to vaginal hormonal therapy in women who don't get the full response we're looking for. And again, we don't really have any good evidence to support the use of vaginal laser for laxity, stress incontinence, and overactive bladder. I just listed here for anyone who wants some of the papers that I referenced. And I thank you for your attention. I hope this was worthwhile, and I'm happy to discuss any questions anyone has.